let's sum this all up, Mark, by talking about these 3 brand new agents that are FDA approved in metastatic HER2 positive breast cancer in combination with those that were previously approved. How is the availability of these new agents going to impact the care of our patients with HER2 positive metastatic breast cancer? How are you going to use these?
Well, just to summarize the data, kind of in conclusion here, for the Destiny-01 trastuzumab deruxtecan trial, the median prior lines of therapy for that cohort was 6, whereas in the HER2 CLIMB trial, it was about 3. So that's important if you're going to be comparing these agents in clinical decision-making. Moreover, the median PFS was about 16.5 months in the Destiny trial, compared to almost 8 months in the HER2 CLIMB trial in the experimental arm. So again, it's a testament to the robust activity and extraordinary responses and durability of response with DS-8201 trastuzumab deruxtecan. The overall response rates are about 61% for the antibody drug conjugate and about 41% for the HER2 CLIMB regimen. But the big difference, really, in my opinion, is the extraordinary data for the patients with brain metastasis that was shown at ASCO in 2020 by Dr. Lin. And just the fact that you can get an OS signal with the HER2 CLIMB tucatinib-based regimen in HER2-positive brain mets, that carries the day for me. So if a patient has brain mets, I'm going to use the tucatinib-based regimen. However, if they do not have known brain metastasis, I will probably use the trastuzumab deruxtecan antibody drug conjugate because of its very high response rate and long median PFS. So I think that summarizes my position currently in patients who have progressed after prior trastuzumab, pertuzumab, and TDM1. What do you think, Julie? Am I right on this notion?
I think my thoughts are similar to yours, and also, our community in general. If there are brain mets, we prefer tucatinib, but without brain mets, the Destiny Breast-01 trial was really impressive. So we're tending to favor the trastuzumab deruxtecan. I think what we're all struggling with right now is these drugs are approved after a couple prior lines of therapy, and wanting to use them earlier line, and of course anxious to start testing them even in the adjuvant setting, especially tucatinib. Can we prevent brain mets? I'd rather prevent brain mets than treat brain mets. So what are you thinking about where these drugs are likely to go in the future, knowing we don't have clinical trials data yet?
I think it's fairly straightforward to move up the tucatinib regimen into second line, if somebody's already had, let's say, adjuvant or neoadjuvant pertuzumab, trastuzumab, and maybe post-neoadjuvant TDM1 even, you can move it into earlier lines because the FDA label says following 1 prior HER2 targeted regimen for metastatic disease, whereas the label language for the antibody drug conjugate actually says for 2 or more prior lines, then trastuzumab deruxtecan is approved. So I think we will be doing some peer-to-peer calls because, as you rightly point out, it's not that uncommon in 2020 to see patients who have already had dual antibody therapy and TDM1 in the early stage disease setting. Therefore, all of these new exciting approaches are going to have to graduate into earlier lines for metastatic disease. Moreover, as you rightly point out, there is a rich opportunity to use these agents in earlier stage disease indeed, particularly as you mentioned, tucatinib. I'd love to see that in a extended adjuvant setting to perhaps replace neratinib because of its higher therapeutic index, for instance. That would be one opportunity. And then the antibody drug conjugate is so impressive in terms of response duration, probably activity in the brain, indeed, based on retrospective subset analysis. That may play a role in early stage disease as well, although we'll have to be very mindful of the risk of interstitial lung disease, as you mentioned in your remarks.
Where might you consider neratinib in the metastatic setting?
For HER2 kinase mutations, I use it regularly for that indication. Outside of that, I could envision maybe somebody who's had all of the agents that we've already discussed in this program and still have good performance status and are, let's say, progressing in the brain and have had whole brain radiation already, and you're really at a loss for anything other than either best supportive care or even hospice considerations versus continuing therapy. In that setting, maybe, but those patients often are so heavily pretreated and are sick by the time they get to that stage, they may not tolerate the neratinib capecitabine regimen well. And so I do worry about that, and I would use it cautiously, if at all, in that situation.
Do you see that you'll ever prescribe lapatinib again?
I can't really imagine that in a tucatinib progressor that lapatinib is going to have any activity. KDs for tucatinib are superior even against HER2 compared to lapatinib. So I would imagine that the mechanisms of resistance would be cross-resistant with two HER2 TKIs like that. So I think lapatinib is going to be the lost stepchild in the situation. I can't really imagine using it with much enthusiasm following tucatinib. All right, our time is up for this program. Thank you, Julie, for your insightful discussion. And thank you to our audience for watching this targeted oncology presentation on precision medicine. We hope you found this discussion to be useful and informative. Julie, any final remarks?
Thanks. You, as always, Mark, have brought up a lot of great points, and you've made me think. So this is helpful, and I know we both want to use this information to get the best outcomes for our patients.